a couple of vibrator recommendations. Those are adjunctive tools. Those are our friend. We don't, I'm always like, any partner that's not okay with a vibrator is probably not for you. But
Welcome back to Talking About the Taboo. If you don't know so already, you know who it's speaking. Natalie Malloy. Hi. This podcast is for individuals who are curious to know everything there is to know about sex and relationships. I really want to thank every one of my viewers, whether it's 7 or 1,000, for coming on here and allowing me to be my true authentic self and helping me help you learn everything about sex, but also giving me the ability to feel confident in what I do. I am super excited for today's episode. We have a guest coming on to talk about menopause. Now, you're probably thinking, Natalie, your viewers are mostly in their 20s. Why, or 20s or 30s? Why? Why are you telling us about menopause? Because there is a such thing as premenopause, perimenopause, but you have to have a sense of power in your health, in your sexual health. Hormones suck. And sometimes you just can't, actually, all the time, you just cannot control what happens. So, this is giving you the power to learn before it even happens, predict the future, if you will. So, please stay tuned. Today's guest is someone who is not only incredibly knowledgeable, but also deeply compassionate when it comes to helping people navigate midlife and menopause. I'm thrilled to welcome Dr. Alexandria Reyes, a board-certified OBGYN and a Menopause Society certified practitioner. Dr. Reyes is the founder of the Magnolia Gynecology in Tampa, Florida, and also runs a virtual menopause care practice serving patients across the entire state. She's made it her mission to support and empower those going through menopause in the transition, including cancer survivors, by providing personalized care and clear, comprehensive education on all hormone therapy options. She has a background in food science from Kansas State, a medical degree from Kansas City University, and a residency at the University of Kansas. She brings a unique blend of science, compassion, and real life perspective to her work. I am just so excited to have her on the show today to talk about everything there is to know about menopause and how we can take charge of our health through this major life chapter. So, if you want to know more about this, or if you just like hearing my voice, stay tuned. And remember, communicate. How are you doing?
good. How are you?
Good. Thanks so much for coming on my podcast called Talking About the Taboo. I'm so excited to have somebody to be able to open up a forum for individuals and give them a sense of power in their sexual health and just health in general. So thank you so much.
You're welcome. Happy to be here.
So before we get into something more serious, I guess, not really that serious, I wanted to do a little bit of an icebreaker with you. So,
Okay.
if you had to describe menopause in one word,
Mhm.
but that word had to be a snack, what would it be?
Oh boy. Menopause in one
Yeah.
word, but it had to be a snack.
So
Oh my
mine
gosh.
was like
Yeah, tell
spicy
me.
Cheeto or trail mix with surprise.
Oh my gosh. Let me think. Yeah, actually I really like spicy trail mix
Okay. All
with a
right.
surprise because you've got so many kinds of things in there, and
Yeah.
then you are not always sure, is it going to be sweet? Is it going to be spicy? Is it, how exactly is this going to come out? Because some people do okay and some really have an up and down roller coaster more often. But
Yeah,
yeah.
exactly.
Uh,
That unpredictive, you don't know what's going to happen. Everybody's hormones and growth
mhm.
is different. I know that
Right.
was kind of like putting you on the spot, but you did
No,
really good.
it's okay. I'm like, snacks. Okay.
So we're just gonna kind of go in, and I want to talk about just the overview of menopause and just like an introduction. So
Okay.
just kind of start with like the basics. So like, can you explain what menopause is and what like the different stages are a little bit and go into detail for
hmm
me?
Yeah, so if we say menopause, that's really just one day of our life. Most people characterize that this like medical definition is 12 months of no period, and then like everything thereafter is menopause, is typically the term you use for everything thereafter. Before that, though, so average age of that is like 51 to 52. This is really when like you really have an effective egg count of zero. So there's no more ovulation occurring at all. There's no more, hormonal signaling to the uterus. There's no more bleeding. But prior to that, and anywhere from 7 to 10 years before your final menstrual period, you are potentially going to be having other hormonal symptoms from the fluctuations of perimenopause. And so perimenopause is it's staged, and there's some scientific staging that we have, but essentially the easiest way to explain it is there's some an early perimenopause and then a late perimenopause, and there's different things in those stages, but essentially the symptoms start out early and subtle, and then they kind of progress into more of the irregular, skipped periods, going for a couple of months without a period. And not everyone follows this exact timeline, but
Right.
this is kind of the book definition. But the shocking thing, I think, to most people is how long it can be lasting in the perimenopause years, which can be the majority of your 40s, even, or, just by average numbers, as young as 35, you can start to experience some hormonal fluctuations and symptoms, even though you're having your period regularly, that are
Hmm.
perimenopause technically, or it's from what I kind of call the declining ovarian reserve. So as that egg count starts to decline, brain hormone signals to ovaries start getting a little crazier, and then you get a lot more of these like fluctuating peaks and valleys, and therefore symptoms or PMS that's new
Yes.
onset, or various things.
I think
So,
the frustrating part about being a woman is that everything can mean everything, or anything can mean everything. You know what I mean? So, for
mhm,
example, I am having cramps and my discharge is changing and I am extremely emotional. Am I pregnant or am I about to like get my period? It's so frustrating,
right.
and how are you able to actually biologically, diagnose somebody as, "Okay, you do have menopause," or, like, what if
Mhm,
they're just having symptoms versus, like, can someone
right.
be 30 and be in
Yeah.
perimenopause and 40 still be in perimenopause? So just kind of go over that for me a
Yeah.
little bit.
Well, I certainly think some of that has to do with, I mean, there are, of course, other conditions. So,
Mhm.
like, part of the evaluation, like in a perimenopausal aged patient. So, I mean, you can go through early.
Right.
Certainly, lab work can be supporting, especially if you're going through a lot earlier. Like if you're skipping full periods and then your hormone levels are clearly abnormal, and everything else is ruled out, like other labs to check for your thyroid conditions, you're not pregnant, other things are normal, then we can kind of deduce that, if it's a cyclic symptom for sure, there's at least some female hormone reason behind it. Now, whether it's truly perimenopause is a little bit different. But a lot of times the labs in perimenopause are actually normal. And it's really a
Mm.
clinical diagnosis, like the menstrual cycles. Are they regular? Are they irregular? What's the timing of these symptoms? What types of symptoms are they? Are they low estrogen symptoms? Are they, progesterone deficiency? So there's like a lot of like things that are mostly clinical. Certainly if you're like way, your 20s, or you're way under the average age where we expect perimenopause, which would typically be 35. Average age of menopause is 52. So but the range is like 45 to 55. And then you can have perimenopause up to 10 years before that. So think about that. Normal could be as young as 35. So if we're under 35 and we're having like symptoms, absolutely we would do labs, and we would, evaluate that person and take a good menstrual history. When are the symptoms occurring? What are these symptoms? And you're ruling out other causes that aren't hormonal, or, menopause, menopause in nature, and then once you've ruled that out, is it meeting criteria for something else? Because certainly in the younger years you've got things
Yeah.
like premenstrual dysphoric disorder, which is like severe PMS, which can be a thing, but
Mhm.
has a clear cyclic association and criteria in and of themselves. But I think like menopause generally, if you're over 35, and you're having a certain set of symptoms, along with menstrual irregularity, we have to think about perimenopause. And it's a
Yeah.
very average time actually to start experiencing subtle to more significant symptoms. So it's kind of just like a constellation of clinical description of the patient, like what she's telling me, and I believe her. And then,
Yeah.
of course, the labs that we may have that support that, hey, it's none of these other things. So it very likely could be. So
What
it
I
takes
find
some
Sorry, go ahead.
nuance. It's just nuanced, I think, with the diagnosis. And there are like clinical and lab criteria that we use as well.
So, can you explain to me how it's possible for a 50-year-old to get pregnant? Can a 50-year-old get pregnant in the middle of going through in the process of menopause? Like, what's the latest that someone
You
you
could,
get yeah,
yeah.
because that's interesting. I've
So
seen this happen.
yeah, you can still get pregnant all up and all the way until you're actually menopausal. So menopausal, remember, would be 12 full months of no period at all. At that point, you should not be able to conceive. Birth control is no longer needed. But technically, yes, even if you're having, say, very irregular cycles, let's say you're in that late perimenopause, or you haven't gone 12 full months, but say you're having 4 periods a year, you could technically have a pregnancy occur and you could ovulate.
So I'm in here with grandma. We're waiting on the nurse to come back with her results and stuff.
Hey, so we got that urine back, and it does say you are pregnant.
What?
It says about 12 weeks.
What?
Were you not expecting this?
No. Go on.
And there are even times, I think, in perimenopause where you could even argue that you might be a little more fertile, in some of those
Oh, okay.
cycles because of the declining egg count. Your brain is really sending stronger signals trying to do its thing, and so you can even, that's why
Mhm.
you hear of like increased rates of twins in the
Yes.
40s and things like that. Same reason. It's not that you are really technically more fertile, but certainly pregnancy can occur all the way up until it's been 12 full months of no cycle at all. So
That's
got to be
kinda
careful.
like yeah, it's kinda like someone getting a vasectomy and it's like, "Oops, that didn't work." You know what I mean? You can't
Yes.
rely sometimes science is just like, "Psych." Like,
Hmm.
"We got you."
Yeah, yeah, yeah. But typically, like vasectomies, tubal ligation, sterilization procedures are really good. But
There's that
yeah, as far
chance.
as like if you're using nothing, you have to kind of realize like, okay, this could happen. So if you really don't want it to, then use proper protection. So
Has there ever been a
yeah.
situation of a client that you've worked with that you were starting menopausal, consultations
Hmm.
with them,
Hmm.
and then all of a sudden they're like, "I'm pregnant."
Yes.
That's happened?
Yeah, it's not that common just because most people, they're either like, in usually I would say
Yeah.
most are like in their 40s, they've already had the vasectomy or the tubal, or they're using other forms of birth control or what have you. So they're like, yeah, very low likelihood of pregnancy. But yes, I've definitely had that happen a couple of times.
Oh, Lord. So, what are the common age ranges? You kind of went over that briefly previously, but I just feel like so
Hmm.
it starts from this date to this date. So, perimenopause is this date to this date, and then we got menopause, then we got postmenopause. So, kind of
Yeah.
go into detail with
So
that for me.
51 and a half, at least in the United States, 51 and a half is the average age of menopause.
Okay.
That full menopause where it's been 12 months of no cycle, no period at all. And then it just really varies. Like it's anywhere from like 2 to 10 years prior to that. So, if you think about youngest natural age where it's like still just it's just normal and average, 45 being the younger end of normal for full
Okay.
menopause, and then just think wherever you fall in that, you could be having symptoms 2 to 10 years prior to that. So that's why I say, like, if you're 35 or over and you're starting to experience night sweats before your period, or new onset or worsening PMS, or anxiety and depression, or brain fog,
Yep.
insomnia, trouble sleeping, vaginal dryness, you just have to really start like tracking that on a cyclic level and like, okay, I have these days where I feel worse and then I get better when my period starts. Very, very common presentation. So like as young as 35, it's not, you have to think about perimenopause because it could just very well be when you're starting. You could be one of those people who's either going to go through a little early, or are you just starting to experience perimenopause on that 10 years before you're going to stop your cycle, or are you in that 2 year till you're going to stop your cycle? You really don't know till you go through it. But I think the biggest thing is like clinicians need to have like that index of suspicion, if you will, and not just
Mhm.
say, oh, you're too young. Because I think a lot of
Mhm.
people think menopause is 50, but like the symptoms having the option of going up to 10 years before you stop your periods is just, it's a huge range. And so it's like, am I doing that, or is this, is this not? And I think that's where having like an experienced menopause clinician is really important. And, that could be a variety of different physicians or practitioners, but you have to really, see somebody who's an expert in it, I think. Dr. Alexandria Reyes, and I'm a board certified gynecologist and menopause specialist. So I see women daily struggling with finding answers to the midlife transition and menopause. Back when I was first in OBGYN residency, I was really interested in just hormones, the menstrual cycle, fertility. And this is just the opposite end of the spectrum on that. And then the struggles I was seeing women go through and not finding the help they needed really kind of just connected the dots for me to this was my calling, this is what I needed to help them. So I provide convenient online telemedicine consultations throughout the whole state of Florida. So I'm able to reach more women with midlife, perimenopause, and menopause concerns and actually have access to a specialist.
Are your services
Yeah.
covered by insurance?
Yeah, we do, like we provide like super bills, and like people do submit to their insurance a lot and can get reimbursed, which is kind of cool. That
Wow,
of course
okay.
just varies per their plan, but yeah, so it's like an itemized receipt, and some of them have good success with getting reimbursed. So um yeah, I think people are looking for what I've noticed in the 4 years I've had a private GYN practice in Tampa, like the I think everyone is looking for quality care. And I think more and more people are starting to really see the holes in the insurance-based system and the, corporate medicine. And I think a lot of people
Mhm.
are really just fed up with that, like, assembly line type of feel. And so I'm definitely not in that category. We spend like a lot of time with, our patients. And so I think that that's really appreciated, and I know it's not for every person, but I also had to self-preserve, as a
Yes.
physician and as a business owner. It was, it's like I can't compromise the time and the care that I give to people, so
Yeah.
that was the only way to do it, unfortunately, and sometimes people don't
Mm.
understand that unless they're on the side that I am, like, trying to run a medical practice, but I take great care in all the decisions we've made, and I think it's honestly it's been the best way, and people get the time they need, they get awesome care, they feel well heard, we get them a solution, they're feeling better, which is like it's so much better than like I spent 10 minutes with my doctor and they told me nothing. And then you're like,
No,
ah,
yeah.
yeah,
Corporate
that's like a waste of
medicine
time. Yeah.
It's corporate medicine is a waste of time, and, well, not always, but corporate
Yeah,
medicine, you
but a
talk
lot of
about that.
times, yeah.
It just
Hmm.
takes away what doctors and, OBGYNs and therapists started their career
Hmm.
for. They started it with compassion, and what insurance does
Hmm.
completely rips apart the compassion part and adds
Yeah.
just a price tag on top of
Yeah.
woman's health, and it's just
It
the
does.
worst thing
And they don't
I
value it a lot either.
no, no, no,
Yeah.
they don't understand it, and the diagnoses and the codes you have to put in if you have vaginismus, that is recognized as a mental health disorder. Are you kidding me?
Mhm.
You're kidding. That's a joke. That's a joke. And
Yeah,
I find so much,
yeah.
comfort in your ideals of that, like, we
Mhm.
understand that this isn't everybody's, like,
Yeah.
financial situations may not fit, but
Yep.
we do offer this, that, and
Yeah,
the
I
other.
try to help as
Yeah.
much as possible. Yeah, I think it's kind of like people physicians are trying to
Mhm.
especially private practice
Yeah.
physicians who've gone out on their own. We're trying to function within a dysfunctional system, and the patients
Yep.
are too, and we're
Yep.
patients too, so we feel
Yep.
it as people who are trying to get health care, and it's just like no way you turn is any of it perfect, but You're so right. Like if I went into medicine because I wanted to care for people and I liked science and I want to help them, I need to do it in a specific way to be able to do that. So you have to figure out how to do
Yeah.
so, right?
Yeah.
So, but I love what I do. It's very gratifying to be able to help people, and see how they are feeling better, which is why I love menopause is that.
Thank you.
So
So moving
yeah.
more closer to like back onto like the menopause train here, we were talking about like symptoms and age ranges, and I just
Mhm.
was wondering if any medical conditions, genetics, lifestyle, surgeries, things like
Mhm.
that impact that at all.
The age, yeah, absolutely.
Mm.
So certainly like certain ethnicities go through menopause a little earlier. And so, for example, African Americans go through a little bit earlier than Caucasians in the US,
Oh.
and sometimes have more severe symptoms. And then things like, so if someone had, a diagnosis of like infertility or diminished ovarian reserve in their 20s or 30s, many times may go through early, because it's kind of the opposite end of the spectrum. It's the same thing, it's just a declining egg count. And then, of course, like certain things like smoking
Mhm.
certainly is very harmful to the ovaries. And then there's certain like less common but happen, breast cancer survivors. Some chemotherapies will cause you to go through like premature menopause or premature ovarian insufficiency, and sometimes your periods come back and sometimes they don't. It depends the age in which you receive the chemotherapy, radiation to the pelvis for other types of cancers. Um, Certainly, other chronic medical conditions can
Yeah.
cause, an earlier menopause. So I think, yeah, absolutely. There's a lot of factors and genetics for sure. I mean, we can't say for sure, oh, my mom went through it 50, so I will.
Mhm.
But it is a factor. Certainly, it's a red flag to me if I hear someone say, my mom and my grandmother went through menopause at age 42. I'm like, and I
Oh,
have a few
yeah.
people like
Ding,
that
ding, ding.
recently. Yeah, it's oftentimes, there's usually a correlation, in my experience.
So what are the typical, like, hormonal changes that occur during, like, menopausal, like, and how do they directly affect a woman's sexual health, libido, sex
Hmm.
life? I'm really interested in, like,
Hmm.
learning more about, like,
Hmm.
the estrogen and progesterone and all those levels and how they
Yeah.
differentiate.
Well, certainly, testosterone, I'll start with that because a lot of people, estrogen, progesterone's like our main ones that run our
Right.
menstrual cycle, right?
Yep.
So testosterone is made by the ovaries, and so it's not just a male hormone, which is what a lot of people think, but it
Mhm.
is responsible for spontaneous desire. So, for example, it's why men have a higher just spontaneous sexual desire versus women have responsive desire a little bit more, to something in their environment or something, a setting, or, something someone, their partner did for them. Whereas, or just versus that spontaneous sexual thoughts. And so testosterone does decline over our lifetime. Like, and so during perimenopause, it's going down. It doesn't just drop off a cliff like our estrogen and progesterone can at menopause. You still have testosterone levels. They may be low, but they aren't going to be, it's not quite the same dramatic situation with testosterone. But as testosterone declines, that's one of the reasons you may see some decrease in sexual desire. And then you also have, like, in I'm going to say the 40s, because that's the most common decade of life that people are in, like a perimenopause
Yeah.
situation. But essentially, when the egg count starts to decline, and that's naturally the way it is, we're born with all the eggs we'll ever have. And then you start to ovulate those at puberty. And then throughout your lifetime, of course, in a normal situation, you're ovulating once a month, right? And you're having that period once a month. When you start to enter like a critical stage of the egg count, because they start just to that you ovulate some, but more of them actually, let's say there's 400,000, you're not going to ovulate all of those, but like a lot of those, the reason that they go away is by this process called atresia, where they just kind of like, just imagine they're shrinking away. So with
Yeah.
age and time, they're really disappearing. And so when you reach like a critical level, um, as your brain hormones from your pituitary gland, follicle stimulating hormone, tries to send signals to ovulate, and then that creates estrogen rise and the different fluctuations you see. You'll start to really have symptoms because it's like that critical low level isn't able to receive the signal properly. And so the brain's starting to really yell at the ovary. I always think it's like a megaphone, like, hey, someone received my signal. And then sometimes it does, a follicle, which is a fluid filled sac with an egg inside of it, it grabs the signal and it's like, oh, great. Oh, that was a lot of signal. And it maybe grows way too fast. You'll get more bloating, you'll get more breast tenderness
Okay.
that cycle, maybe some abnormal bleeding. So you have some high estrogen symptoms like that can occur. And then you'll also have, when you get a little bit more in the process, like further along, you'll have periods of time with really low levels. And those are like night sweats and hot flashes and vaginal dryness, sometimes irritability, insomnia, brain fog. And so there's a kind of like there's a lot of symptoms. They say there's like
Yeah.
30 something. I think there's like 130 something. Like there's so many things that are becoming, that we are learning, that are associated. And it really takes like listening to like the cycle as to like, okay, does that make sense to be a cyclic issue? You have to really have a good understanding of the menstrual cycle. And then essentially, like, I would say earlier on, though, what happens is low progesterone. And the reason that's happening is that in a normal situation, you ovulate, let's say on day 14 of a menstrual cycle. And then from there on, your progesterone levels rise and they're like waiting for a pregnancy essentially. And then 14 days later, if there's not a pregnancy, you bleed. And so in that half of the cycle, the luteal phase, you're really getting high progesterone levels naturally. Well, as you reach that lower egg count and your brain's yelling at the ovary and it's like not happening, because there may be a cycle where it just doesn't happen properly and you just don't ovulate. And so you'll have more what we call like anovulatory cycles, which are essentially low progesterone cycles. And so I think a lot of people in really early perimenopause actually do pretty well with just like progesterone supplementation, even without estrogen yet, because it's really just more of a like milder symptoms that are from the lack of progesterone. That's really like the first hormone that declines because of that lack of ovulation, because of the egg count being low and the hormones are trying to tell it to ovulate. And it's like, no dice. So that happens first. And then as you progress along, you'll start to hear the patient say, like, I was doing okay and it kind of regulated my cycles, but now I'm having more night sweats and brain fog, or what I would characterize just as low estrogen symptoms, and we need to add estrogen in. Or if they're having these estrogen high symptoms like bleeding or breast tenderness or a lot of bloating, or even emotional, people
Yeah.
will absolutely respond to even adding estrogen because it just stabilizes out these big swings that are happening. So it's kind of like this instead of like this nice curve that
Roller
you're getting
coaster.
before perimenopause, you get a lot of really high ups and downs. And to go back to your question about sexual health, I think testosterone is one piece, but really what's probably a little bit more common is that anovulation, or that lack of an ovulation occurring. That is what kind of takes away that natural fertility that a lot of us have mid-cycle. If you're not on birth control and you ovulate, that pre-ovulation phase and at ovulation is really when most people feel like that natural fertility rise of like natural sexual desire. I would like to have sex. That, that's kind of that phase is occurring, and that's kind of removed from some of the cycles. And so for various reasons you'll see that. And then I also think that you will have, if you're having a lot of sleepless nights, let's say you're not doing well with night sweats, or just insomnia without night sweats occurs, or a week before your period you feel terrible, a lot of times libido is going to decrease as well. So lots of things for like desire. And then of course, as you get further down the line of it, you can start to experience more significant like low estrogen vaginal dryness, pain with sex, which then feeds back to less desire. And so
Yep.
there's a lot of things of the ways it can relate, and the way it affects like your pelvic floor and the nerves
Yep.
and the vaginal tissue and the vulva and the clitoris. And there's all these things. So, but I think in general, there's like, it affects it. Yeah, absolutely. Most people notice some
Mm.
waxing and waning of their desire for sure, even all else being normal. So,
And is there any way, like speaking to somebody, hey, like my libido, I just like feel like I cannot have sex with my husband right now. And I feel so bad. I don't know what to do.
Mhm.
When they come to you with these, sexual concerns, how do you
Mhm.
address it? And how do you kind of give them maybe like a recommendation and how to help it? Is there like any medicines or just like techniques or
Yeah.
exercises?
Yeah. So, I mean, I always want to know when someone, because I ask them all these questions. And
Yeah.
so I always want to know
Thank you for
if,
asking the questions.
yeah. So I always want to know, like, is the low libido or the low sexual desire, like, first of all, is it personally distressing? Is it disruptive to you, right? Or to your
Mhm.
relationship? Because there are people where it really isn't. And so we don't need to just, put everybody on medication.
Yeah.
But certainly, usually, if they're bringing it up to me, um, some of them are meeting that criteria for hypoactive sexual desire disorder or HSDD, and they say, hey, I used to feel differently. It's been pretty distressing. I don't have as many sexual thoughts, fantasies, different things, for the last year or what have you. And so we talk through, we call it like the biopsychosocial model. So we're talking through things, sexual response cycle starts in the brain. So there are some things that are purely hormonal, then there are other things like I mentioned, like pain conditions, which may have a hormonal component, may not. Like you mentioned, vaginismus, different
Yeah.
causes. So the first thing you want to kind of know is, like, is there pain? Is there, how is the relationship? Is there any untreated mental health disorders? Because untreated anxiety and depression is very
Yeah. Yeah.
common, and then feeds back to that. So I kind of just go through like a head to toe, like mental health, physical health, hormonal health, how's your cycle? And then if we're, to a level of, treatment, so there are various things I can recommend to patients. So I can just kind of mention some of those things before
Yes.
pharmaceuticals. Sometimes we'll do, I always recommend erotica reading. So finding a
Yes.
genre that you actually like, and
Smut.
that's so personal. Right. So that's so personal. So I recommend the Rosie app a lot. Like, take a look at their library or find an author you like, and whether that be audiobook or just reading, because it seems to be, women especially respond better to that reading material, even more so than visual. And so I think that's a really important thing to know. It's an evidence-based way to really increase desire.
Yeah.
And then if I give out, I definitely give a couple of vibrator recommendations. Those are adjunctive tools. Those are our
Love it.
friend.
Love it.
um, we don't, I'm always like, any partner that's not okay with a vibrator is probably not for you. But
Yep.
anyway,
It is your
it's not a
friend.
competition. Yeah. And then let's see what else. And then I always recommend the omgyes.com website, because there's an interactive vulva on there. And so you can really find
Oh.
novel techniques, like partners get involved and they're like, oh, we can try this or that. And, just understanding our bodies change with time. Then I always like to like optimize hormones. So if we are in a perimenopause, menopause situation, like vaginal hormones are so important, usually as a foundation for like the base of like, making sure the tissue is responsive, the blood vessels are healthy. And then of course, like sex therapy can be, something to recommend, as well as pelvic floor therapists actually have
Yes.
quite a bit to offer in and outside of pain conditions. Obviously, if there's pain, absolutely. And then even without pain, pelvic floor physical therapy techniques have been shown to help enhance sexual health and desire, and just like pelvic blood flow. So there's like a lot of things that are not pharmaceuticals that we really talk about first, including mental health, the relationship, hormone health, all of that. Is there pain? Of course, has to be excluded and treated. And then, as far as like, if we say the pain is not an issue, or we have treated that successfully, or maybe in conjunction, we may need to treat you with something pharmaceutical. And so right now, we essentially have three options for women. One is testosterone and 1/10 the male dose. And then
Okay.
we have Addie, which is oral medication. And that one basically acts at the brain level on serotonin. And then the third one is called Vyleesi, which is another effector of the neurotransmitters in the brain. And that one's more of on demand. It's done like as needed
Mhm.
situation. And those are desire type medications. And then there are some new exciting things coming out and hopefully consensus guidelines on some other very novel, interesting medical treatments for orgasm
Weed?
dysfunction. Mm-hmm.
What's your
But
stance on weed? I'm hearing some
oh,
taboo
yeah.
things coming up here.
Yeah, so that is something that is, and I think I'd have to look it up for you, but I
Mhm,
just was at the Ishwish conference about a month
mhm.
ago, and they're the International Society of Sexual Health for Women, and essentially they went over. There's a ton of options. It can be helpful. That's
Yeah.
correct. THC. There's actually a whole bunch of other things, but obviously with anything, it's like dose response related, so you want to be
Yep,
careful. I
yep,
mean, they talked about because if you go too far the other way, you may have the opposite effect.
yep.
So, but even like different types of like microdosing of psychedelics and just oxytocin and things that affect dopamine. It's all because that sexual response starts in our brains. And so, desire, arousal, orgasm, resolution, like it's all actually starting and finishing in the brain. And then, of course, the pelvis responds
Yeah.
in the ideal normal setting. But there's things to do for all of it, I think. And the biggest thing is like I think women especially have to kind of understand like things do change over time hormonally or just in longer term relationships too. And like mental health affects it a lot and like stressors and little kids and just different things in our lives that can make things really different. And then one of the other big things I always remind people is that, something like scheduled sex is not a bad idea. It's recommended actually it doesn't sound so spontaneous, but it's really great in creating those pleasurable experiences. So again, as long as we're having pleasurable, fun, good experiences, it's going to feed back to the brain as I want to do this again. So I say, if it's not a good party, why are we going to it? Your brain's going to know, like, I'm not really interested. That feels dry like
Mhm.
sandpaper, or I never have an orgasm. Why would I do that again? So it's kind of important it is very important to realize, like, if we can schedule those encounters, we'll actually many times get desire that comes after arousal from physical touch. And so
Mhm.
by having more of that, it really feeds back to increased desire. So it's really awesome. Like we can do a lot without medications,
Yes.
just by educating. And I think, people knowing what's normal, there's really huge range of normal and
Mhm.
literally anywhere from I don't have sex too often and that doesn't bother me at all. Our relationship's great. I don't really want to change anything. That can be normal all the way to, something else in the opposite end. So I think there's no normal. Like people just have to. It's whether it bothers you, what your goals are, what are we trying to do? Is there any pain? What do we need to fix? What are your goals? That's how I always want to frame it because it's like it's not necessary for every person that checks that they have low libido on a form to do something about it necessarily, but if they want to, we have lots of tools which are great.
I always tell individuals who are going through a multitude of just sexual dysfunctions or concerns or symptoms to keep like a sexual diary, like have like
Hmm.
a separate notebook, be like, this sex was great. This sex sucked. This sex hurt. I smelled like this. And just, you know what I mean? And it's like, I used to have an
Yeah.
app. The app's called Corazon. And the app, honestly, was to keep track
Hmm.
of people who I had sex with, how good it was, how many orgasms I had, if I was ovulating. It was just such a
Yeah.
cool app. You can do it
Yeah.
on an app or written down, depending on what. I
Mhm.
just feel like that is
That's
super
great. I actually
beneficial.
really love that idea. I tell them to do that as well for just straight perimenopause symptoms. So I'm like, track. So if we're not immediately starting hormone therapy or we're not really sure yet what's going
Mhm.
on, I'm like, track your symptoms. Not only your bleeding, but like, yeah, like if you have increased desire, if you have increased orgasms, if you have
Yeah.
night sweats, or you're having terrible insomnia. Like I'm like, if you have a good day, write it down. If you have a really bad day, let's also write that one down, like at
Yeah.
bare minimum. Right? Like you don't have to be super detailed every single day, but if it's like a really great or a really bad, let's kind of look at where that's at in a menstrual cycle. If the
Mhm.
person is in perimenopause or still having periods. So, yeah, that's an awesome idea. I love journaling anything.
Me
So,
too. So say they're taking, they're writing down in their journal and they're noticing some like differentiations, some like, ooh, maybe I should like get that checked out. What do you think is the best time for somebody to go to somebody like you who specializes in menopause besides just kind of going to their gynecologist, like either yearly exam?
Well, some gynecologists are menopause specialists. Like I'm a
Yeah.
gynecologist by training. So you have to kind of figure out if your GYN is someone who is very well
Okay.
versed in perimenopause. So there's a few, I have a couple, I think I've done a couple posts on Instagram about that, like how to find out if your doctor is menopause literate.
I'll link it down
Um,
below.
but yeah, yeah. But I think that you can definitely find out if your GYN is one of those people by asking a few questions. I think certainly if you feel dismissed or if you're like, okay, like, I don't think she was getting what I was saying. I do highly recommend to make a dedicated visit outside of an annual wellness if you do believe you're having hormonal concerns or
Mhm.
perimenopause, menopause concerns, or even just anything PMS, like something that's really a big issue for you, sexual health for sure. Make a separate appointment from your annual. And then if you still don't feel heard by your GYN or whomever you're seeing for those annual wellness GYN checks, absolutely that's when you want to start seeking out, maybe more of a sexual medicine or menopause trained, depending on the issue. If something doesn't feel right, you're having difficulty, like if it's affecting you, your relationship, and I'm talking like sexual concerns, if you have a problem with any of that, you should be able to have a consultation and talk through it and say, this is affecting me. What do you think? Like it could be going on, and you really need to start ruling out reasons and then come up with a treatment plan. And the same thing goes for hormonal changes. Like if you don't feel okay, you don't feel like yourself, how you used to be, if there's an issue, I think you again bring it up at a dedicated visit and go through. But essentially anything that's cyclic, that's new onset, absolutely has a hormonal association. So if you didn't used to have terrible PMS and now you do, it's got a hormonal cause, at least partially, right? So there has to be some teasing out of why those things are occurring. But I always just think the journaling is a really great place to start.
Yeah.
And then if you feel like, yeah, I'm having issues here that I did not feel like myself anymore, I think that's super important to just to
Keep track
ask
of and
about.
yeah.
But I wouldn't, I mean, not to say you can't, yeah, I would track it and then I would bring it up at a separate appointment. And then if you don't feel heard, then try to find a more specialized clinician for those specific things. So
So what specific like lifestyle changes do you think individuals who are in perimenopause or going through menopause or postmenopausal can kind of change to help, themselves like as such as diet and exercise? Because I know there's weight gain with hormones. What would you recommend to like change for that?
yeah. Yeah, for sure. So certainly I think 40 and over, just averaging on ages, people really need to start focusing on, you have to really be looking at nutrition more, and I would say exercise and the type of exercise you're doing. So you probably see it all over the internet. The weight training is really being emphasized. And so I do think that that is a big thing that most women need to be doing or introducing. And so, weight training or muscle maintenance or building is the best thing you can do. People are like, how can I naturally balance my hormones? I would honestly say weightlifting.
Ooh, what's that? Brother, ooh,
Baby, do you know that's what
brother, ooh.
heaven is a place?
So,
Okay.
if you gain muscle mass, you are going to decrease insulin resistance. You're going to increase your basal metabolic rate. And then to do that, you also need adequate protein in your diet. So we always recommend to track protein, fiber intake to keep
Add
blood
that to the
sugar from
diary.
spiking. Yeah. So honestly, if people are just, they're not looking to like necessarily lose weight, but they're just looking to optimize health, I'm always like, at least have an idea of how much protein you get, fiber, dietary fiber, and then added sugars. You want to keep those low.
Okay.
And so, obviously, if you're trying to actually lose weight, you probably need to pay attention to all of your macros and different things like your carbs and your fat, and your protein. But by and large, like people don't get enough protein, I would say, or dietary fiber. and we get too much added sugar. So I say those three just to kind of think of an indicator of like, what should I be looking at minimum? And then the weight training, you know, you hear everybody saying to lift heavy. I really like the term progressive overload better, because it really just means like, don't stick with the same 8-pound weights you've been using for the last 5 years. Like, you need to be increasing your weight and, you know, lifting to fatigue and really challenging your body. And I think that's really what we mean. I think a lot of people are like, what does lift heavy mean? You
True.
know, or they don't know how to lift. And so I think it's like lifting to fatigue. So in that set, you know, the last couple should be very difficult. And then the next time you do that exercise, you should probably be going up on weight, or you should be, you know, at some point. And so that's really what, you know, weightlifting is not, or strength training is not just like lifting the same weight and the same exercise for 10 years. That's not going to, your body acclimates and it's not really helping. Right. But yeah, so it's more like that progressively lifting a little bit more. So we always say strength training. The fiber should be definitely a big one to be looking at, and just in foods. Even you don't have to supplement, although a lot of people don't get enough, so they do. And then you've got your protein macros to look at. And yeah, strength macros on, let's see, fiber, protein, um you know, getting your steps in every day, to be honest, like that can really bump metabolism up and help with weight loss too. Like people who are at plateaus, or they're like, I'm gaining a little bit of weight. It's like, get your 7,500 steps a day, or, you know, really track that.
Good.
So those are the big things I usually say for lifestyle. And then also it helps bone health, right? So keeping our bones strong. But yeah, I would say diet and strength training have to really be fine tuned, because you can't, the hormone changes of perimenopause, they lead to insulin resistance, which is the way our body like manages carbohydrates and metabolizes things. And so any little blood sugar spike often can, you know, lead to body fat storage. And so it's very different and more delicate, I would say, as you're entering the perimenopause years. You just can't get away with what you maybe could at 25. So it's just something important, I think, remember, is that like, it's all something that can be worked with and supported, but it's usually multiple ways, like hormone therapy, lifestyle, diet, strength training, you know, mindfulness, meditation, making sure
Yeah.
you're, you know, adequately doing what makes you self-care, you know, just different things for you, and having the right team. You know, you need a sex therapist, you need a pelvic therapist, and not everybody needs all these people, but you know,
Yeah.
knowing what's out there and like what you can be doing for yourself, and how to find the right clinician when you need the help. That's the biggest thing I see, is people not finding what they need, or having gone to 5 doctors, and then they'll be like, you're the
Wow.
5th person I've seen, thank you so much for listening. And I'm like, you know, the system
Ugh,
is failing people. And
yeah.
yeah, it's not uncommon. It's really, there's great care out there too. So I'm not saying it's all bad, but I mean, when you look at the whole population,
Yeah.
sometimes it's a little sad to see how many people are still having to see multiple doctors before they really get some good help and answers. So,
Yeah.
but that's
Speaking of
why I
like
exist.
the
I love it. So,
yeah.
yeah.
Speaking of like the misalignment, I have a segment I kind of wanted to talk to you about. It's called
Mhm.
Taboo Talks Questions to Communicate. And we in this segment go over just the myths that people may believe about menopause. Like, it's not a disease. Okay, it's a part of life. And I also want to
Uh-huh.
go over some
Yeah.
listener write-ins. Do you think you want to do that?
Yeah. Sure.
Yeah? Okay. So I'm
I'll
just gonna
do my
start with some
best. Yeah.
yeah, you're gonna be fine. So I'm gonna start with some listener write-ins first. Hey, I'm Brandy, and I'm facing a full hysterectomy this summer. They'll be removing my cervix, and I'll be getting a vaginal cuff. I keep hearing horror stories about how after the surgery, if you have sex at any point, the cuff could tear and then your internal organs could fall out, which is freaking me out. Also, they're leaving one ovary so I don't go into early menopause. But without a cervix, how do they check for ovarian cancer since I won't be able to get a pap smear? Just looking for some advice and maybe some reassurance. Thanks.
Okay. So the vaginal cuff is essentially, so once that cervix and uterus are removed, we sew the top of the vagina. Okay. So when she says vaginal cuff, we're talking about, I think of it like the inside. If you looked inside of a sock and you saw the seam at the top,
Mm-hmm.
that's like the
Okay.
cuff. So that's like, it's just like a blind pouch, if you will. And so that if as long as you allow full healing before penetrative sex, you should be just fine. The doctor will clear you like at 6 to 8 weeks, and depending on age, you may or may not need to be using vaginal estrogen to like help. You should ask the doctor about that, like to see if that's something that you may need. And younger people, you don't need it, but you might. So that's always a question, just to speed healing along. But typically, I would say 6 to 8 weeks is a really normal healing time of that. And then once, if as long as it looks normal, you're okay to have sex, and you don't have to. I mean, um, that opening up late is very, very uncommon. So no worries. Just make sure you're cleared with the doctor before engaging in any penetration or any heavy lifting. Just follow the post-operative instructions that they give you.
Okay.
Um, and then I think your other question in that was the ovary.
Yeah, checking for ovarian
Um,
cancer if she only has one
mhm.
ovary.
So just remember that pap smears are really cervical cancer screening tests. So that's really all that they are testing for. So you'll still get an exam every year, and the doctor will still check the ovary. So when we do a pelvic exam, we check the ovaries to make sure we don't feel any masses or enlargement. The only really true way to screen for or detect ovarian cancer is to do an ultrasound. Um, but even that isn't perfect. So we don't just screen everybody with like a periodic ultrasound. So ovarian cancer is tough. We don't have it, but the hysterectomy is not. Whether you have one or you don't, that one ovary that remains, there's always the potential of something occurring with it, whether that be a cyst or a benign, you know, situation or
Mhm.
an ovarian cancer. But the hysterectomy doesn't affect your ability to detect that or not.
Okay.
We're still all with the limitations of
Yeah,
we don't have great ovarian cancer screening actually. So
it's
going
unfortunate.
in for symptoms or going, or just doing your exams is important.
So
So
to reassure her, her organs are not going
mhm.
to fall out as long as she
No,
takes the proper steps.
very, very likely. Yes, it'll be good.
The next person I'm going to move on to, this one's a little bit
Yeah.
shorter.
Yeah.
Hey, it's Sandy. Supposedly, I went through menopause and didn't even know it. LOL. No hot flashes, no period, no, my labs are good, and no crying, no mood swings. It's like I barely noticed anything happening. How is
Mhm.
this happening?
Don't say that too loud. You'll make all your
Other
friends
other people jealous?
jealous. Yeah, I would say that experience is not that common, but it does
Hmm.
happen. I would say probably well over 90% of women will experience something. Now, whether they attributed it to menopause or not is the thing, and obviously severity varies. But there are people like Sandy that really don't have any
Wow.
symptoms. It's pretty uncommon, though. I think what it is sometimes is that people actually just attributed up some of the symptoms to something else. So I'll have
Okay.
people be like, well, is it just getting old? I guess my joints are hurting and I can't sleep as well, but I thought it was just getting old. But actually it's actually hormone changes. So sometimes it's just subtle symptoms
Yeah.
that are not really recognized right away anyway. So but
Wow.
yeah, I
Lucky
mean, great. I'm
Sandy,
glad for
huh?
her. Good for Sandy.
Is there any other kind of myths or questions that individuals ask you when they come to see you that you think that people listening to this podcast could really benefit from
Mm,
hearing?
myths, or let me think. Um I think it's very common to hear people say that, and I hear this from them telling me their clinicians or doctors tell them this. So, a lot of people are under the assumption that if you're in perimenopause and you're having your cycles, your periods are coming, but you are having symptoms, that you cannot use hormone replacement therapy yet or menopausal hormone therapy. So, that's just a term that means estrogen, progesterone, essentially of some variety. And that is not true. It is not birth control, but that is a very common thing
Okay.
that I hear people say. Or like, if you're not really menopause literate or trained, you'll hear the doctors tell their patients many times, like they'll only offer them birth control in that phase because that's just all that they know how to prescribe typically. Or they'll say, no, you can't do hormone therapy until your periods are fully stopped, which is
Mm.
kind of mean a little bit because if the
Yeah.
person doesn't want to take birth control, or
Or
say
it
it didn't
can't.
work for them,
Yeah.
um, or it can't, whatever it is, it kind of then limits their options, or they're given antidepressants or something like that because that'll help sometimes hot flashes or mood
Yeah.
changes. But like they kind of leave hormone therapy off the table if they're still having periods. And I think
Mm.
it's due to a couple things. I think just clinician knowledge and not knowing how to do it and being worried it's going to like cause like bleeding abnormalities or not really just not knowing how. And I think that's what's kind of missing in general OBGYN education anyway, is like we don't get a lot of focus on menopause during our primary residency training. And so you can't really fault people. They're trying to do their best to keep up
Yeah.
on OB and how to do surgery and all these things. So you really have to have a special interest in the menopause patient or perimenopause to like do an awesome job at it. And so, but yeah, that's a really common one I hear is like, they told me I couldn't have hormone therapy until my periods fully stopped. And that's not true. So that's a really common one I hear. Um,
Those are all
can't think
good.
of
If someone wanted to kind of look you up and find you, give me the sneaky links. Where can we find you?
I'm most active on Instagram. So I am at dr.alexandria.reyes. And so I do a lot of educational posts on there. And then like in my bio, I have like the link to book an appointment, and a couple other links to like frequently asked questions about menopause, perimenopause. I also have a website, dralexreyes.com. And those are the best places to find me.
If you had to leave somebody with one last thing that is either, in their 20s, or perimenopause or going through menopause, what would you say to them?
If you don't feel like yourself, find help. Like persist and find a doctor that will listen to what you have to say and make sure you're validated, make sure you're being evaluated, make sure you feel comfortable with the assessment. A lot of people hear, you're too young, it's okay.
Mhm.
And, or you're just getting older, or you just have kids that are waking up at night, or what have you. And I think if you feel something's off, you know yourself best and just continue to persist and, go to a different clinician or physician if you need to. There's nothing wrong with getting another opinion. So,
Thank you. Thank you so much for being
yeah.
open and honest and really educating our individuals, for answering the questions that probably the regular GYN wouldn't go into detail about. I appreciate it.
I do my best. I love it. So I'm here if anyone needs it.
Awesome. Thank you.
Thank you so much.
Obviously, we've come to this point where it's time for the sex toy of the week. Today's sex toy of the week is foreplay. Foreplay, guys. Since when are we getting rid of foreplay? We're never getting rid of foreplay, okay? This is something that I got from literally the mall at Spencer's. It's called Steamy Sex Games, and it has multiple different sections. These sections include the Dirty Truth or Dare, Sexy Scavenger Hunt, Dirty Disco, Finish the Fantasy, which is my favorite. Get him hot game, Daring Dice, Sexy Tarot cards, and a Week of Passion prop play. So I'm going to pull a card for us here under the Finish the Fantasy one, which I love. Okay, let's pull it. Finish the Fantasy. You're working late at the office. All of your coworkers have gone home, even the cleaning crew. Suddenly, you hear footsteps coming closer to your desk. You sit very still, wondering who it is, when you see a shadow right outside your door. And phew, it's only me who decided to surprise you. I walk in, sit on your desk, smile, and finish the fantasy. Oh, oh my God, this is my favorite section. Fantasies are a way to dive into our core desires. If you are a cuck, right? You have a cuck kink and you don't actually want to watch your girlfriend or boyfriend go have sex with somebody else, fantasize about it. Foreplay with it. Get a dildo, stick it on the wall, fuck that dildo while you suck his dick. Just give yourself the ability to completely be your full kinky self without having that expectation that, oh, we have to really do this in real life. You have a threesome fantasy, talk about it, say, oh my God, yeah, that's right. Like, we're going to be fucking her, blah, 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 blah. Just talk about it. You don't always have to act in real life because sometimes some of us aren't emotionally stable enough to get there, or our fantasies are just fantasies and they don't always need to be acted out. Thank you so much for listening to today's episode and really giving yourself the sense of power to know everything there is to know about menopause and how it affects your hormones and your libido. I think this was a great way for us to just continue educating you about all of the topics. The topics literally are endless. I love you all. And with lots and lots of lube, remember, communicate. Bye.